Next, I'll welcome up Dr. Michael Ioannidis to speak on the aging kidney, an old age problem.
Thank you.
I would have caught you.
Okay, thanks. I want to express my gratitude to Ravi specifically for the possibility to attend this extraordinary meeting. It's always a pleasure to be here. So the topic, the old kidney or the kidney of the aging man, I have no conflict on this topic except the fact that I'm getting old and my patients are getting old. And I think this is an important topic. So for those who don't know where Austria is, this is this little country in the middle of Europe. We're having about 9 million inhabitants now. And this is our population distribution now in about 2020. And this is the predicted population as it will look in 2050. And what we see is that a significant increase in the yellow bar, which is the age above 70. And not even that, when we are looking at the peaks, so we're at the peak, this is the prognostication of the age distribution. And when you look at the lines, so this is what we had 2000, and then we had 2010, and this is 2020. You see the peak of the population going continuously upwards. And this is a prediction, and the predictions are not so bad. They were not so bad there. We do this on our statistics and our large intensive care database, and it's going up. The peaks we will move forward to 70 in the next 30 years. But this has impact on the intensive care units, and this is the admission distribution on the ICUs with regard to age. And when you're looking at the patient's age between 60 and above, you see this is now 2020. This will be 2030, 40, and 50. We are reaching enormous amounts of patients in that age, and they will be admitted to the ICU. There are different scenarios on the European part. This is data predicted from the COVID study. I will take you later. So today we're having about 20% of patients being above 80. In 2050, it will be about additional 20%. So we're having 40% above 80. And it will depend whether our ICU capacities go up, and we will have more room for these patients, or whether capacities don't go up, and we'll have to select the admission of these patients to our ICU units and think about therapies. Well, this is an imminent problem, and it's worth considering. And when patients are on the ICU at that age, they are not just healthy. This is data from the very old intensive care patient study. It's mainly European patients. These are the patients above 80, and you see that the frailty, about 40% have increased frailty, 30% have decreased cognition, and there's about 40% of comorbidities in this population. As with age, all the organs seem to be less going down in the capacity, whether it's the brain, if it's pulmonary function, heart, or a skeletal muscle, and of course it's also the kidney, and that's what I want to address our interest in the next few minutes then. It's a combination of morphological changes and functional changes we are confronted with. And just starting with a simple measure is the volume of the kidney. This has been investigated as an additional analysis of Framingham study. As you can see, there's a clear trend in the total volume in both men and women over age going downwards. So the volume of the kidneys is gradually decreasing. This is, of course, not only influenced by age, but the question whether the volume is going down or whether it's going less down also not depends, in addition to age, on sex. Obviously, it is that women have lower volumes as men. It depends on the body surface, but it depends also on the associated comorbidities, whether patients have a lower GFRs in terms of chronic disease or having diabetes, and then they tend to have difference. So low GFR have smaller volumes, diabetes have usually larger volumes. So, but it's not only the whole volume of the kidney, and the the people, Wang and co-workers, were looking at distribution of volume changes by measuring cortex and medulla separately. And correlating to the data I showed you before, male genders had to attend increased volume in the cortex. Older age was associated with lower volumes in both cortex and medulla, and additional parameters like comorbidities also influenced those parameters. But on an overall, when you look at on a net, this is the first set of slides, the men who tend to have larger volumes go down in the overall volume. And when you look at cortex and medulla, both cortex is strongly inflicted. So it is mainly cortex which is reduced in volume, versus medulla is staying more or less stable, a little bit compensating. And then in the ages at higher, about 17 above, then it's going down. If you correct it for body volume, the differences between sexes is disappearing more or less, but the trend is the same. Cortical volume decline, medulla firstly compensating a bit and then also declining. So overall there's a loss in kidney volume. This is associated with a loss of functioning nephrons. This is a nice study done in living kidney-deceived donors who have been biopsied, calculating the nephrons. And as you see, there's a constant decline in the number of nephrons, starting from the age 30, actually, going down through the higher ages. And with this, it's associated as the number of sclerotic glomeruli. This is a bit increasing. And with this associated, you find a reduced GFR, which just reflects the loss of a number of nephrons. So the overall concept is that you have congenital factors which define the number of nephrons you have. And then by aging and comorbidities, you have a certain rate of sclerotic, the development of sclerotic atrophy of the glomeruli. These are reabsorbed or disappearing, resulting in less functioning nephrons. The idea is that you have some compensatory hypertrophy of the nephrons still remain, but the question is if this hypothesis is really true. Further discriminating in the cortex between the changes in the outer middle part or the inner parts of the cortex shows that overall the glomerular volume is decreasing with age, so it's outer, middle, and inner parts. But what is interesting is only the outer parts of the cortex where the number of sclerotic glomeruli is significantly increasing. So it seems to be mainly the outer parts of the cortex which are suffering from disease process versus just aging processes. So non-sclerotic degeneration of the glomeruli is happening overall in all parts of the cortex. Which leads to the concept that you have changes in the glomeruli become sclerotic by different disease processes over the whole cortex, whereas aging-associated degeneration or dysfunction, so non-ischemic sclerosis or nephrosclerosis is happening more at the superficial parts of the cortex. Overall, the number of nephrosclerosis, so the non-comorbidity associated nephrosclerosis, is as the volume is, as the number of non-functioning glomeruli is increasing over time. So the older you get, the higher is the number of nephrosclerotic parts you have in your kidney. And this is independent, even if it's corrected for patients who have hypertension, the same trend remains the same. Interestingly, even if the patients have a low numbers of nephrosclerotic aspects, they show the same decline in GFR as patients with nephrosclerosis. The other part which changes in the kidney is the development of cysts. These are the number of cysts detected in cohort in healthy patients in a healthy study where MRI was performed in a large population sector. And the number of cysts is clearly associated with higher age, so then higher number of cysts is associated with a higher age. Then it's so the number of cysts you find just by doing MRI is increasing. On the other hand, it's not only the number of cysts which is increasing. If patients are followed up for the cysts within the kidney, these cysts also have the tendency to increase per se. So it's not only the number of cysts, it's often also the size of the cysts, which is increasing over age, leaving the remaining number of functioning kidney tissue being lower. There is, however, some people are declining, are showing regression in the cysts, but this is not very homogeneous. So these morphological changes, of course, are leading to functional changes. And this is a graph we depicted following the data from meta-analysis done on measured GFR over age. And what you can see that there is a steady decline from the of the GFR, which seems to be more important or seems to be more pronounced in men than in women, which is the blue line, the men, which is declining a bit faster. The other thing what is quite interesting is that with the decline, you're reaching actually the limits which you usually use for defining CKD. Despite this is just a normal aging process and GFR is going down, many people reach the CKD diagnosis, at least in terms of GFR, just by the normal decline. The decline in GFR, and this is a very old but very excellently done study, is associated with a decline in renal perfusion. And the black bars here on the upper is the changes in renal perfusion, which is continuously going down in per age associated with the decline in GFR. Okay, this was only until the age of 60 and above, so mainly younger people, but you see this overall continuous decline. And this is associated with less of response of the renal vasculature, for example, to sodium load. So you see the difference with sodium load and no sodium load. And this response is getting lost over the age. So the response to the metabolic demand and vascular relaxation is just diminished. And this is the same data we're seeing for stress for giving acetylcholine. What is interesting, and this is a study which included just only patients above 70 and above, doing serial creatinine and cystatin C measurements up, say there were patients included were nearly 100 years. So we are going to really to the high age, and when you're using creatinine-based estimations of GFR, you see a linear decline. This is going very low, so above 90 you come to ranges of 40 GFR, estimated GFR. This is not the case when you're doing a cystatin-based or cystatin and creatinine-based estimation. Then you get more like a nonlinear, and it seems that the decline of GFR in higher ages is slowing down a bit, the creatinine-based, the influence by muscle mass probably, and that is the reason. Overall, you would think that when we are losing about 500,000 nephrons per decade and end up with about half of the nephrons we have when we started in a younger age, the single nephron would compensate for the loss of nephrons. But interesting, this is not the case. The single nephrons stayed quite constant. So what does this mean? Probably this means when you're losing the nephrons, but the single nephron filtration is constant, that you don't see this in the day on average renal function, but it probably reduces renal reserve. So meaning that when we're having the aging kidney, we're not starting here with the renal reserve, but we're starting here. Meaning that there's not any renal reserve left the older the patients are getting. So to summarize, we have several changes in the kidney. So there are changes in the vasculature, including hypertrophy, hyperplasia, atherosclerosis, and increased vessel stiffness resulting in renal blood flow. We have changes in cyst formation and over a number of glomeruli following the nephrosclerosis and the removal of functioning, reduction of functioning nephrons. GFR is reduced, although single GFR remains the same, and the overall kidney volume, especially the cortex, is going to be decreased. This has significant implications. These functional changes, we find the GFR and renal reserve is reduced, then there's a loss of concentrating ability and the disturbed electrolyte homeostasis. And I think what is really relevant is I think hardly any pharmacy prescriptions are considering these changes in GFR in age. So medication dosing really has to be newly rethought and newly adapted. And we have to deal with diuretic resisting and risk for acute kidney injury. Let me just finish. We know that AKI risk is, and this is one of the key studies a couple of years before, that this is highly associated with age. This is not only the physiological aging, but the increase in comorbidities. The problem, I think, is that when we're looking at KDIGO guidelines, we are not considering high age at all. We don't know if the KDIGO guidelines work in the very old. We don't know what is the ideal perfusion pressure in patients who have nephrosclerosis or having some reduced functionality in the renal vessels. And we also have to consider that the outcome of the elderly patients is significantly impaired in AKI, which will influence our decision making. With that, I thank you for your attention.